Hello, everyone. Nice to see quite a few people turning up. So that's really cool. So basically, my name is Dr. 𝗀𝗏𝗃. I'm a consultant radiologist. And what we're going to be doing is going through some cases. It's not going to be too complicated because we're going to be doing a series of these over the next few months. In the beginning, I'm just going to go through some basic stuff. And as time goes on, I'll kind of bring more challenging things to the forefront and hopefully get you guys a bit more challenged with some of the things that we can talk about. Also, it's going to be very sort of based on your feedback. So if you say these cases are too difficult, then fair enough, we can go through more simple cases or less difficult cases and then work our way up. Or if you think these are too simple, we just go from next session onwards to be as hard as possible, basically. So I'm just sharing my screen. I just want to make sure that everyone can see my screen. Sadul, can you tell me whether you can see my screen?
Yep. Yeah.
Okay.
Looks good.
What I've done is just uploaded a few cases to the global platform, and you should be able to access these cases as we go along. This should make things slightly easier for you guys in case you don't have a great connection, which can happen for some people, and they won't be able to see the images as well as they'd like to. So you can kind of work through it at the same time. You don't have to do that if you don't want to. You can just look at my screen. Hopefully you can see what's going on. So, like I said, basic stuff in the beginning. If you do have any questions, please throw it in the chat function, and I'm more than happy to try and answer people's questions as we go along. And like I say, trying to make it as interactive as possible. It's really great when people kind of give their thoughts and to see what they think is going on. But otherwise, yeah, feel free to just, I guess, enjoy the ride if you're into that kind of thing. Right, so the first case is a pediatric patient that has got this unfortunate situation of having fallen over. I don't know if you guys have got kids, but yeah, my kids are always falling over. And when they fall over, I'm always stressed out. They could end up having a more significant injury. But then being a radiologist, there's only so much I can really say without having an X-ray to hand. So I guess that's part of the fun of being a radiologist. So when we're looking at this X-ray, I mean, we've got two views. We've got the sort of more AP and we've got a more lateral view sitting there, but you can already hopefully see quite a lot. And as we go through, I'm going to try and explain some key anatomy to be able to sort of get you to understand what is really happening and how to pick up. If you can pick up these, you hopefully be able to use these tools and ideas to pick up more bigger fractures later on. Right, so pediatric X-rays can be a little bit difficult from the beginning, right? You've got growth plates, okay? So that's one thing to worry about, right? Growth plates can be a bit misleading, especially if you don't have very much in the way of experience when it comes to growth plates. But growth plates have a very, very specific look to them. And so if we kind of zoom into here, you may be forgiven to think that this over here is a growth plate. So I'm just going to get the pen, which is a really cool new function from Collective Minds. So you can kind of draw like this and draw like this. You think that could be a growth plate. Yeah, it could be. But when you look at growth plates, it should really get more corticated as you get closer to the edge of a growth plate. And what I mean by more corticated is that as you can see, as you come to the edge of the bone, you can see the sort of how the bone gets slightly thicker. And that should happen as you get closer and closer to a growth plate. Also, you should have the same situation when you get closer and closer to a blood vessel. So you've got blood vessels that go inside the bones and that kind of thing as well already. And sometimes you can see them on the X-rays and you kind of think to yourself, is this a fracture? Is this not a fracture? How can I tell? And the way to do it is to basically look for increased cortication as you get closer and closer. Because if something's been around the body for a long, long time, the body's had time to kind of accommodate it and put down its foundations so that it's actually a normal structure rather than an abnormal structure. But when you get abnormal structure, and what I mean by abnormal structure is a fracture that's been introduced out of the blue. That's never been there before. The body hasn't had time to sclerose, try and heal. Nothing has happened. And so you end up having a very different appearance from an acute injury when you've got compared to something that's been there for someone's lifetime. So when we're looking at this particular X-ray, when you're looking at an adult patient, one of the big things you want to look for is the radial head. But this is quite a young patient, and you may be able to say that there's no radial head ossification just yet. The whole 𝗀𝗃𝗃 thing is something that we can talk about. 𝗀𝗃𝗃, for those of you that don't know, is 𝗀𝗃𝗃𝗃. So first of all, the first thing to really come about is going to be the capitellum. Then it's going to be the radial head. Then you've got the internal epicondyle. Then you've got your trochlea, which is sort of way back over here. But the point is, generally speaking, it's good to know the order, but yeah, it's very good to know the order. But there are other things that can help us try and identify what is going on in this particular X-ray. So as you kind of come closer to this one, you can hopefully see that there is this sort of radiolucency that is sitting over here. And you think, oh, is that a growth plate? Is that not a growth plate? You zoom in a bit. And you don't see much in the way of cortication as you get closer and closer to those edges. It kind of sort of merges into one's ill-defined, as one would say, kind of very, very ill-defined, and it doesn't continue all the way through from what you can see. So this is going to start ringing a few alarm bells straight away. So the sagittal, the lateral view is kind of what's going to give it to you. And for those of you that can't see it, don't worry, I'm going to work my way through it. So you've got something called the posterior fat pad. And when you've got a young patient, it can be quite difficult to see the posterior fat pad. But here, if I zoom in a bit, oh, hang on, let's get rid of that and go to zoom. And I might have to window a little bit because I know some of you guys have got varying screen possibilities, but you can start to see that there is a kind of almost hypodense area that is kind of pushing outwards from the elbow joint and pushing outwards like so. And that is known as a posterior fat pad. A bit more difficult to see in pediatric patients, I give you that, but as you kind of get better and better at looking at these x-ray scans, x-rays, you'll be able to see that kind of thing a lot better and appreciate that there is what looks like a joint effusion. But don't worry, if you can't see that, no problem. Sorry about that, I think someone's at the door. But the other way to do things is to use something called a champagne glass sign. So I'm going to draw the champagne glass like so. And you can see that, right? It looks like a bit of champagne glass. You're having a nice little cocktail or whatever it is. And if the champagne glass is broken at its neck, then you're probably looking at a supracondylar fracture. So in this particular situation, if you drew a line all the way down like so, and then kind of come in this way, you can see that there is what looks like a radiolucent line with no sclerotic borders sitting at the anterior edge of the cortex of the humerus. And that was more like, that's going to be in keeping with a fracture. It doesn't have that normal sclerotic appearance of a normal structure. On top of that, it does look like there is a break of that champagne glass, which would be this thing over here. And also what you might notice is that it's slightly angulated. It should really be a straight champagne glass, not an angulated champagne glass like this. So all these things together makes you realize that this is going to be a fracture, and something very, very important not to miss. And believe me, although this is a slightly easier case than others, I've seen these things get missed. And the other thing I'd like to say for anyone out there is, even if you don't see the fracture, if the champagne glass looks normal and everything looks aligned, but you still have a posterior fat pad that's raised or a big joint effusion in the context of trauma, you still need to raise the possibility of a supracondylar fracture, even if you don't see the fracture itself. Right, so as far as I can tell, there's no questions coming in just yet. So we're going to go to the next case.